Welcome to the Asthma Neuromodulation Special Interest Group webcast. I'm Dr. Keith Scarfo, and today I have the privilege of introducing Dr. Allison Engel, who will be presenting on neuromodulation patterns of stimulation. Dr. Engel is a board-certified anesthesiologist and interventional pain physician at the Spine and Nerve Centers of the Virginias. She's dedicated her life's purpose to solving gender and genetic differences in chronic pain. After earning her bachelor's degree in biochemistry, she attended medical school at the George Washington University. Dr. Engel completed her residency at the Johns Hopkins School of Medicine and her interventional pain fellowship at the University of Pittsburgh Medical Center. Her research projects have encompassed translating basic science and clinical trials with a focus on genomics, chronic pain states, and engineering.
Neuromodulation, patterns of stimulation. We will first cover the introduction, go through definitions, mechanism of action, patterns of stimulation, conclusions, and address some questions. Introduction: neuromodulation with spinal cord stimulator devices. Spinal cord stimulators consist of electrode leads that are placed in the epidural space to stimulate sensory tracts. The mechanism is not completely understood. It is complex, but it is thought that electrical stimuli modulate the pain pathways via the spinal thalamic tract and the thalamocortical projections to the cortex. This is accomplished through different patterns. Some are tonic, high frequency, burst, closed loop, dorsal root ganglion, each of which we will go into. Pain processing begins with transduction, where stimuli generate an action potential. Then, transmission is the action of propagating that signal via the afferent pathway from nociceptors to the sensory cortex. The third step is modulation, which consists of a negative or a positive modification of the pain signal along the afferent pathway. The fourth is perception, which is the integration of the pain signal into the consciousness state. We'll focus on neuromodulation, step 3. So physiologic pain signaling begins with transduction, with tissue injury, stimuli bind first order A delta and C nerve fibers, causing the gating of sodium and calcium channels to have an influx and voltage gated sodium channels to open, generating an action potential. Second, transmission, where pain signal is propagated from the nociceptor to the sensory cortex via the spinal thalamic tract. The nociceptor terminals release excitatory transmitters that activate postsynaptic receptors on second-order neurons. Step 3 is modulation, either positive or negative signaling of the pain pathway through the spinal thalamic tract, which can take place in the thalamus, the brainstem, or at the spinal cord. This is where neuromodulation devices perform their action. A recap of physiologic pain signaling includes the first-order nociceptive neurons, second-order, and third-order. The first order consists of the A delta and C fibers that deliver the sharp, intense tingling and burning pain sensation. The second order consists of the wide dynamic range neurons that are A beta input and A delta and C fiber input, nociceptive specific neurons, and then the third order neurons consist of thalamocortical projections that are relay cells and reticular cells. The mechanism of action is complex and poorly understood, but rests on the gate control theory, which states the electrical stimulation of the large A beta fibers suppress pain transmission of the small unmyelinated A delta and C fibers. Stimulation of the large A beta fibers are thought to produce the paresthesias. The modulation is thought to occur at the spinal cord level in the ascending dorsal column fibers and the descending pain modulatory system. Patterns of stimulation largely depend on the device, the program, and patient characteristics. such as positioning. A few examples of patterns of stimulation include tonic spinal cord stimulation, high-frequency spinal cord stimulation, burst, closed loop, and then dorsal root ganglion stimulation. Traditional tonic spinal cord stimulation targets the dorsal column axon fibers. Paresthesia coverage of pain is considered a necessary but not sufficient requirement for efficacy. Here, mapping is the critical factor to achieve pain relief. Activation of dorsal column fibers releases glutamate, which binds to and activates inhibitory interneurons. Activation of inhibitory interneurons causes release of the GABA neurotransmitter, and GABA binds wide dynamic range neurons, causing a hyperpolarized state. The end result is reduced pain signaling to the brain. High-frequency spinal cord stimulation has a different target. It is thought that it targets the superficial dorsal horn rather than the dorsal column. This is a paresthesia-independent stimulation pattern where paresthesia coverage of pain is not required for therapeutic efficacy. The theory is that the 10 kHz stimulates activation of the inhibitory interneurons located in the superficial dorsal horn, without stimulation of the dorsal column and without release of the excitatory glutamate. Activation of inhibitory interneurons causes release of the GABA neurotransmitter, which binds wide dynamic range neurons, causing hyperpolarization and again reduced pain signaling to the brain. Burst spinal cord stimulation is also thought to target the superficial dorsal horn rather than the dorsal column. Burst consists of a very low current, around 0.1 to 1.5 milliamps, allowing for a paresthesia-free therapy as well. Similar to tonic, burst spinal cord stimulation modulates the lateral spinothalamic tract as well as the thalamocortical projections to the somatosensory cortex. Burst additionally modulates the medial pathway, which is responsible for the affective and attentive components of the pain. This is thought to be related to specific patterns of thalamic burst finding. Closed loop spinal cord stimulation is most likely targets the superficial dorsal horn as well. Paresthesia coverage of pain is not required for therapeutic efficacy. Sensory stimuli that reach suprathreshold elicit an evoked compound action potential. The device senses the stimulation-induced ECAP and adjusts the electrical output based on the ECAP recording. This allows it to maintain the desired stimulation regardless of changes in the patient's posture or position. The end result is closed-loop neuromodulation provides feedback to maintain evoked compound action potential amplitudes near a target amplitude for that patient. Another pattern of stimulation is DRG, also dorsal root ganglion stimulation. DRG targets are well mapped and anatomically organized, allowing for a highly focused treatment area of pain. The theory is that the stimulation modulates pain transmission occurring at the DRG soma, which is the connection to the axon, the T junction. This T junction filters action potentials, either allowing their propagation or blocking their transmission to higher sensory systems. The end result is specific stimulation of pathological DRG to achieve focal pain relief. In conclusion, A delta and C fibers are the primary nerve fibers responsible for the perception of pain. The A beta fibers are responsible for the sensation of touch and pressure. GABA is the key neurotransmitter responsible for pain relief taking place with traditional tonic stimulation. Traditional tonic spinal cord stimulation targets the dorsal column, and it is thought that high frequency targets the superficial dorsal horn, and as well as burst, and specific patterns of thalamic burst firing add to the additional medial affective pathway of pain perception modulation in burst spinal cord stimulation. Closed-loop spinal cord stimulation records ECAPs and adjusts the stimulation output to effectively maintain appropriate neurostimulation therapy during patients' positional changes. DRG stimulation allows for a highly focused treatment area of pain targeting the T-junction, which is thought to play the key role in DRG stimulation.